I will talk about the new ProX NX3 microcatheter, and that I showed you yesterday also during the live in retrograde epicardial crossing. It was really hard case, but I think that the microcatheter had a really good behavior. This is a double braid microcatheter, so we have two kinds of microcatheter, coiled and braid. So the coiled microcatheter are the one that you can spin a lot, like Corsair, like Turnpike Spiral, or Turnpike LP, or Mamba, and you can turn a spin in clockwise or counterclockwise. And then we have a braided microcatheter, like Fine Cross, Caravel, and Enhancer, for instance, and in which you cannot spin because you risk to damage the microcatheter, but you can have some slowly movement, 90 degree from on the right and on the left to help the crossing and the performance of the microcatheter. And this one is a double braid with a core wire inside. And I've seen really improvement on respect of the old series. And you can see also here the crossing performance of also other microcatheter on respect. You can see Corsair Pro, Caravel, Turnpike, and NX3. And we have really an improvement of this performance. Moreover, we have an additional technique that we can do only with this new microcatheter is the hybrid locking. You can see here. You can lock, and normally you have to go like yesterday I showed you, like 5 centimeters close to the Y connector. You can lock with the torquer and the wire inside. And at this point, you have one fixed system between the microcatheter and the wire, and you can push the microcatheter gently with the two hands, the right hand on the torquer, the left hand close to the Y connector, and you can advance the system in some situation then we will discuss. The potential application for this hybrid locking is to increase the guide wire penetration, power, puncture in the proximal cap, uncrossable. Some situation we face so hard a calcified lesion that we are not able to advance to push the also very stiff wire, and we have many techniques try to overcome this problem, to go behind the calcium, but sometimes we have not the space for doing technique like scratch and go or a balloon or base technique. So in this situation, the application, the possibility to lock the microcatheter and the wire to increase the power, we know that we can increase up to 10 times the power of our wire penetration is very important. Then we have the possibility to modify the tip. We have a sort of surgical precision of guide wire shape and direction, and then the ProX NX3 catheter lesion crossing. You can see here then that with this system, the evaluation in vitro by IMDS of the penetration power demonstrate that like filler XT with the ProX and locking is 10 times more efficient, more powerful than without the locking. And the power of filler XT become quite similar to the potential power of Miracle Bros 12. So up to 10 more penetration power for soft wire, up to 3 more penetration for stiff wire. Also the possibility to have this surgical precision of guide wire shape direction. In this situation, you have to go very close to the tip of the wire, and with this possibility, you can lock and you can push and increase your power and to modify the tip it depends on situation and our lesion. And if you can see here, the lesion crossing will, in the in vitro testing of this microcatheter, demonstrate much higher penetration power of this new technique. And also we have a study of James Pratt evaluating the old microcatheter, so the microcatheter, the original Pro X that was not so efficient, so performance than this one. It was an older version that he showed that in some cases in which it was not able to cross with the normal technique, with the hybrid lesion, hybrid technique, he was able to cross. In this situation, you can have a slow rotational drilling with the right hand on the torquer. I will show some cases. In my experience, I use normally in retrograde approach, like yesterday, I have only this case of antegrade approach. You can see this situation. We have a tortuous occlusion of the right, and we went in proximal in antegrade fashion, and this was failure XTA that failed. We change, we have a step up with Gaia second that crossed the lesion. And we were able to advance the microcatheter quite easily because of its really good performance. Also, we didn't need to use a guide extension, and we crossed, and then despite the angulated vessel, we were able to advance the micro and then have a good result. So, as I explained you, we try to use this new device in a complex situation, like in this case. This was a complex CTO with the septal and epicardial connection. As you can see here, there are tortuous connection. You can see the epicardial and also the septal on the right. We start with the epicardial crossing in this situation, and with the SUO 03 and the enhancer NX3. That was really good to advance in this very tortuous collateral. You can see here in real time the crossing, the loop of the epicardial, and the fantastic behavior of the microcatheter. Then we use the Gideon for the re-entry, and we have this good result, but we have an occlusion of a very big PDA, so we cannot conclude the procedure in this way. So we had to do a second retrograde from the other tortuous collateral. This case was the septal with the same SUO 03 wire and the same microcatheter. So we use the same first enhancer Pro X NX3, so it showed that also after very good behavior in the epicardia was not damaged. This is the advancing of the SUO and the microcatheter. Look at how many tortuosity of this collateral. And on the left, you have the behavior and the crossing of the Pro-X. So look at the guiding catheter movement. At this time, I make the tip injection to understand the anatomy of the connection that was not so clear. And then a puncture with the gladius. Inside of the stent strut that I implanted half an hour before. And then I had to cross the stent strut with the microcatheter. And I was able to cross without any problem the strut. I perform the re-entry. I do the IVUS to confirm that the gladius is inside of the struts. And this is the advancement of the Pro-X. And the final result. So in this situation, I think we have seen the utility of this microcatheter in this very complex situation. So this is another case, post-LAD CTO, post-cabbage and lima occlusion. We try antegrade, but we failed, so we need to go retrograde. We need to use a dual lumen for engage the collateral. This is a very useful technique when the takeoff of the collateral is angulated. You are not able to select the vessel without dual lumen. So this technique is very useful to have side branch access. After that, the crossing with SUO-03 and of the epicardial. In this situation, I was surprised how this microcatheter have a strong support for doing the procedure, because the Caravelle is a fantastic microcatheter, but in my experience, when you have this, you need to use this micro. Sometimes you have problem of backup support to complete the procedure, and it is important to have a good balance between the crossing capacity and the support. In this situation, I was really surprised about the support of the Pro-X, because I was able to advance, you can see here, and then I had the possibility to do a knuckle with the Conquest CP12, because it was the only way to conclude the procedure with the reverse cart. And in this case, to have a good support from behind from a microcatheter is really essential. So you can see here the good push of the microcatheter, and the knuckle here with a very stiff wire was the only way. I failed with Gaia 3, I failed with the soft polymeric wire, and the only possibility was to do knuckling of a very stiff wire. But in this situation, if you have a microcatheter that doesn't have the possibility to push, you lose your position. The last case is very recent, of 1 month ago, is this circ occlusion. I failed to go antegrade with IVUS and other technique, and I need to go retrograde by this epicardial. And so NX3 and SUO-03, good performance. At this point, I was not able to cross with the Pro X because of the tortuosity of the epicardial, and I tried to use this hybrid locking technique for retrograde, and this is the final part of the advancement of the Pro X. And this situation is very important to look at of our wire, because during the locking system, for sure we have an advancement also of the wire, because the system is as a single one. But in this case, I've seen really the difference with this technique. We have a short video of test using the guide wire locking. You can see here that the microcatheter stops at this level. Then you advance the torquer and you lock the torquer. In order to have a fixed wire and the microcatheter together, you have to look at the wire that is completely fixed with the micro, and then here I use a different technique. I take the left hand pushing and the right hand. You have to keep the guiding catheter in order to have a good backup, and then the left hand here and the right hand on the torquer. Then we have the Gideon 5 was the ipsilateral retrograde connection. So with the 8 French guiding catheter, we can put inside a Gideon 5 French in order to have the re-entry in the circ, doing trapping with the trapete, and retrograde final good results. So we have seen many situations which this microcatheter make the difference. So I think that it's very important now. We treat every day much more complex patient, much complex lesion, and having the possibility to have these new devices with high performance, it's very important for us, because we increase our efficiency and our success also in this very complex situation. Thank you very much.
Thank you, Roberto. That was exciting. The only thing that I would like to ask you is to clarify how you really move the device forward, because you cannot spin it, you cannot push it, you push it, but the device has some capacity, some tricks that you rotate gradually. So why don't you just tell us your experience?
It's very important. Normally, it's like, as you know, also with the Carvel or with the fine cross, we learn from the past that we can have a slow rotation of 90 degrees from right, and then we come back, we push, and we can have a slow rotation on the left to help the microcatheter advancing in complex situations. So I suggest to first to push normally, and then to help our microcatheter crossing, and wait some second, because the microcatheter after some second you will see that can advance by himself because of our slow rotation. So our slow movement, we cannot spin fast as we spin with the Corsair or with the Turnpike LP, for instance, which we go very fast, and the spinning helps the crossing. Here we have to be careful not to spin, but have a slow movement in one side or in the other side, and then we have the possibility to have some improvement in our advancement in the lesion.